Hello friends, now I will be talking to you about seizures disorder. So before I discuss this topic, let's learn some basic concept. As you know, in a live person, in the brain we have a regular electrical activity is going on, and this discharge are asynchronous. So in a normal live brain, we have asynchronous discharge from the neurons. But sometime a group of neurons, they discharge in a synchronous way. This is a very important word. There is synchronous, hypersynchronous discharge from a group of neurons, and that is known as seizures. So in other words, we can say, there is disturbance in the electrical activity of the brain. Thereby, a group of neurons, they discharge in a synchronized way, that we call as seizures. Now, how patient can manifest clinically? Patient can have motor features, sensory features, autonomic or psychiatric. The patient can have manifest this way clinically. Now, if these seizures are occurring again, recurrent, then we call as epilepsy. That is, recurrent seizures are known as epilepsy. And if a seizure has motor feature as clinical feature, then we call as convulsion. So remember, convulsion is a type of seizures, but all seizures are not necessarily convulsive. That means patient with the motor feature are convulsion only. Okay, this was a few definitions that we got to know about seizure disorder. If two seizures occur concurrently within 30 minutes and patient does not regain consciousness to normal level, then we call as status epilepticus. Two seizures within 30 minutes without regaining normal consciousness. Okay. Now you are clear about the various terms regarding seizure disorder. How we classify the seizures? First is the partial seizure. In the partial seizure, the disturbance of electrical activity is confined to one focus in the cerebral cortex. One focus. or disturbance is in the a limited area. What are the subtypes? A, simple partial seizure. Here the patient is conscious. That means there is no disturbance of consciousness and there is a focal feature is there. Second is complex partial seizure. C for complex partial seizure, also known as temporal lobe epilepsy. Why temporal lobe epilepsy? Because in this, temporal lobe is involved in around 80 to 90% cases. Now, what are the features? It is same as simple partial, but additional feature here, patient is unconscious. Unconscious. Third is partial seizure with secondary generalization. The patient has abnormal electrical activity confined to one portion to begin with, but later on it spreads in the entire brain. The patient start with partial or focal seizure, ultimately it becomes generalized seizure. So we call it secondary generalization. Now let us see what are the important feature of focal seizure. They are never idiopathic. They always have some structural abnormality. That's why when a patient of focal seizure come to us, CT or MRI or brain imaging is mandatory. Number two, they have a well defined aura. Patient comes to know that epilepsy is about to occur. The well defined aura is a classical feature, and in fact this point differentiates from generalized seizure. Remember, generalized seizure can be idiopathic, and in generalized seizure they have a no aura or they have a ill defined aura. Third, Jacksonian march. Is again a feature of partial seizure. The seizure start and one focus, and as the disturbance of electrical activity spreads to other part, that is so called Jacksonian march. And after the epilepsy is over, patient may have some residual deficit, and that is known as Toad's palsy. Toad's palsy, again a feature of partial seizure. Then one more thing what can happen in partial seizure is deja vu phenomena. In deja vu phenomena, a unknown persons look very familiar. And similarly, we have one more term called Jamia's view. Even a known person looks very unfamiliar. So all these what we see in focal seizure or so called partial. Grand mal epilepsy, also known as generalized tonic clonic seizure. Generalized tonic clonic seizure, also known as grand mal. The feature are, it's of sudden onset. It may occur in any posture. Patient may be standing, patient may be lying supine. This is very important. Why it is so important? This point differentiate from syncope. Syncope occur only in standing position. Okay, and there is sudden loss. Patient becomes suddenly unconscious. Remember, in syncopal attack also, patient, as I told you, is occurs in standing position. Patient falls. Patient may transiently lose the consciousness, but patient regain consciousness immediately or instantaneously in syncope. Here it is not so. Now what happened? Patient become unconscious, so definitely if he is standing he will fall. He will fall, that means he may sustain some injury also. Then all the body muscle they go into, the patient after this all body muscle they go into contraction. And this is known as tonic. As all the body muscle are contracting, so that can lead to contraction of jaw muscles also, that can lead to tongue bite. Tongue bite. Now I like to share something, a peculiar thing about tongue. Tongue is a completely muscular organ and it has no bone, and while the person is awake, tongue is constantly moving, especially while talking, while eating, while chewing, it is constantly moving. And the tongue is being surrounded by 32 teeth. Still, in a normal person, tongue bite is usually never seen. But in epilepsy, tongue bite occurs. It may be very badly bitten with this profusely bleeding also. So once you see a patient with a tongue bite with bleeding tongue, then you should always suspect about the epilepsy or seizure disorder as a etiology. Now I told you all the body muscles are contracting, and after that patient has, after a few seconds or a minute, muscle relax, and that is known as clonic phase. Again muscle contract, relax, and that's why tonic clonic process occurs. Well, this process lasts for about 10 to 15 minutes. And remember, patient is unconscious. And one more classical feature which is described about tonic clonic phase. When this all is going on, onlookers, those who are looking at the patient, they are always scared of looking at the patient. If the ladies are around the patient, they usually scream, they cry when they look at the patient. Well, after this episode over, and when the patient is having tonic clonic phase, during that time patient may urinate, or patient may even defecate also. Okay. When the episode is over, patient lies unconscious for a long time, then he slowly regains consciousness, and patient may have headache, or he may not remember what happened. This is known as post-ictal amnesia. He doesn't remember what happened. Amnesia is there. This was regarding grand mal epilepsy. Now we talk about absence seizure. Absence seizure are typically seen in children. They are seen in children, and there is transient stoppage of the ongoing activity, like a daydreaming. Patient may have transient episode of like blinking of the eyes like this, or some chewing like this, blinking or chewing. But one of the main highlight is postural fall is not a feature. Postural fall is not a feature. And this episode can occur hundreds of times per day. And the first time when it is noticed is during poor performance in school. Poor performance in the school is the first time when it is noticed. And EEG is classical EEG, that is 3 Hertz spike and wave pattern per second is the classical spike and wave pattern, is the classical EEG that we get in this patient, right? Then we have myoclonic seizures. Myoclonus. It is more commonly seen in children, especially in the morning hours. This sudden jerk-like movement like this, a current-like, shock-like, may involve one limb or one side of the body or the whole body. Okay. This is myoclonus. But remember, myoclonus can occur in a normal person also. Normal person also. Quite possible that you may have experienced this, especially when you get up, suddenly you find a shock like, and your one limb or one half of body or whole body goes into contraction. This is myoclonus. But remember, again repeating second time, myoclonic can occur in a normal person. But otherwise, myoclonic seizure are classically seen in Creutzfeldt-Jakob disease. Okay, so this was some of the broad classification of seizure disorder. Now let's see what are the causes of seizure disorder. So I have written this thing. You can take the printout, or those who are not having printout, you can stop the video and you can first note it down. Okay, so now then you can start the video again. Well, what is the etiology? This mnemonic is there. Mnemonic is vitamin. V for vascular. I for infections like meningitis or encephalitis, head trauma, autoimmune, metabolic, idiopathic or neoplastic. Well, this grand mal epilepsy, also called generalized tonic-clonic seizure, especially in children, is idiopathic. And one more thing, focal seizure or partial seizure are never idiopathic. Okay. Now one more thing regarding metabolic. The There are many metabolic disturbances which can produce a picture like seizures, like hyponatremia, hypocalcemia, hypomagnesemia, hypoglycemia, or hypoxia, hepatic encephalopathy, and renal failure. They can lead to, they are all metabolic conditions which can lead to seizures. Now, why it is so important to discuss this now? And of course, I have written also investigation. Now, a patient come to us with seizure for the first time, and till now we have discussed very clearly that it is a disturbance of electrical activity of the brain. Should we do EEG first? No. First you rule out these causes, because even if you get abnormality in EEG, but if the cause is hypocalcemia, hypomagnesemia, or hypoglycemia, you have to treat these basic causes, not for epilepsy, because once you correct hypoglycemia, the disturbance of electrical activity will disappear. Same thing, all whatever so called treatable causes. Got it? So remember, when a first time patient comes with seizure, we first do all these things. So what we have done sodium, calcium, magnesium, glucose, ABG, LFT, KFT, CT head. Why CT head? To rule out neoplastic causes, trauma, infection, or sometimes vascular also. You like to investigate urine for toxicological, because there are very toxic compounds, especially drugs also like aminophylline, which can lead to seizure. And if all these are normal, then you go for EEG. Then we presume that this is not, none of this cause is there. Perhaps it's idiopathic is there, right? Then we start for the management part. So patient has come to us with all these problems. What drugs we can use? There is nothing like single drug. We have a group of drugs that we can use. Well, for generalized tonic clonic seizure, we can use lamotrigine or valproic acid as the first line treatment. Same thing with myoclonus also. We can use either lamotrigine or valproic. But for partial seizure, we can use lamotrigine, but we can also use carbamazepine, as the first line treatment, oxcarbazine, what about absence seizure? Ethosuximide is the drug of choice, first line treatment. Otherwise, we can use valproic and lamotrigine also, L for lamotrigine. This we can use. Regarding lamotrigine, is one of the main side effect is its severe skin reaction. It can even go for Steven Johnson syndrome. regarding valproic acid, it is absolutely contraindicated in pregnancy. Now, what are the newer drugs available now? The newer drugs available are stiripantol. It increases GABA. We have retigabine, which is a potassium channel opener. Perampanel, it is a AMP antagonist. It rather you can say. This is how it has got the name also. We have progabite, it increases GABA. Rufinamide, it is pretty used for Lennox-Gastaut syndrome. So they are the newer drugs which are on the pipelines. And one more thing I like to make you special note, retigabine is the only drug which has a unique action of potassium channel opener. Okay. Now, regarding patient has come to us, we have done EEG. Now, we are giving the drug for 3 years. If the patient remain asymptomatic for 3 years, then we can plan to withdraw the anti-epileptic drugs. Now, how to withdraw? What are the indications? How to show withdrawal? Of anti-epileptic drug. First of all, 3 years symptom free. This is the first thing you got to know. If patient has no symptom for 3 years, we can plan to withdraw. Number 2, withdrawal should be always gradual over a period of 6 months. It should never be sudden. Should be withdrawal 3 to 6 months, ideally for 6 months. Now, suppose at the time of withdrawal, you plan and you do go for EEG. If EEG is abnormal EEG, when we are planning to withdraw drug, should we withdraw the drug or not? Abnormal EEG is not a indication to stop the drug. You can very well stop the drug if patient has no symptom for 3 years. But chances of recurrence are much more if patient has abnormal EEG at the time of withdrawal of the drug. But again repeating second time, you can withdraw the drug. Abnormal EEG is not a hindrance to stoppage of the drug. Well, we are treating the patient, but at time patient may come with a status epilepticus. Okay. Now, what is status epilepticus and how we have to manage? Now, let's see. Regarding status epilepticus, what is the definition? I have already told you the patient has 2 episodes of seizures or epilepsy within 30 minutes without patient regaining consciousness in between. It's a very serious condition because mortality may be as high as 10 to 20%. Why mortality is so high? Because of various reasons. Because these patients are more prone to have respiratory arrest, tongue may fall backward, it may block the upper airway, patient may have aspiration pneumonia, patient may have rhabdomyolysis, because repeated severe contraction of the muscles may damage the muscles. Hyperthermia can occur. There are the few reasons or what complication can occur in a case of status epilepticus. Now, why happen? What are the causes? The causes include, most is sudden withdrawal or stoppage of the drug, usually by the patient, or what we call as non-compliance to treatment, or patient may have some trauma, tumors, some infection. What we in fact we have seen in the causes also. So all the potential treatable causes, they may come with the patient like status epilepticus. Now, how to manage? Remember, status epilepticus is a medical emergency. Patient should be treated in a intensive care. So again, you note down or you can take the printout. Yeah. The first thing is patient should be managed in the intensive care. Neurology intensive care. First is to maintain the airway, breathing and circulation, so called ABC. Is to be done first. Then you may have to even intubate also. Necessary, you can intubate the patient. Then treat the potential treatable causes like hypocalcemia, hypoglycemia, hypomagnesemia. Okay, and you give IV thiamine, especially where patient has in hypoglycemia, glucose, especially in alcoholic patient also is mandatory. Otherwise, it can precipitate Wernicke's encephalopathy or Korsakoff psychosis, and naloxone can be given. Once we have done this general management, then we talk about specific management. First of all, we give lorazepam or any benzodiazepine. Lorazepam is a much more commonly used. If not controlled, then you can add phenytoin or we can add phenytoin. We give infusion. Phenytoin is less toxic as compared to phenytoin. If still not controlled, then we can go for intravenous phenobarbital. If still not controlled, then we go for general anesthesia, we can go for thiopentol. This is the line of management of status epilepticus. Now a word about alcohol withdrawal seizures. Patient chronic alcoholism, suddenly you withdraw the alcohol. If suddenly stop, it can precipitate alcohol. But these patients are not to be given long-term treatment for 3 years. They are usually managed with a shorter anti-epileptic treatment. Now, the last thing is about surgical treatment, especially in those patients where there is mesial sclerosis. Mesial hippocampal sclerosis is there. They are resistant to drug therapy and they should be managed by anterior temporal lobectomy. So surgical management is done in this particular condition. So this is all about seizures disorder. Thank you very much.